Hello, everyone, and welcome to the PT on Ice podcast. My name is Christina Previtt. I am on faculty for the Modern Management of the Older Adults course, and I am definitely the early bird. I keep trying to figure out a way to get myself to be on here at 8:30, and it always seems to not work the way that I want it to. So today, I'm actually super excited to talk to you guys because I wanted to go over some of the exercise prescription guidelines for older adults. And then I wanted to talk about how we as clinicians can apply some of these guidelines. I'm sorry if it's a little bit loud in the background. We do have classes going on at Stavoff, so it might be a little bit on the louder side. Okay, so before I assume that physical therapists know the exercise prescription guidelines, I want to kind of go through what the guideline says. So the American College of Sports Medicine published their latest update for the exercise prescription guidelines for community dwelling older adults in 2009. So the assumption with those guidelines is that it is for older adults who are relatively healthy, over 65, and living in the community. That's a really important point because if there's other chronic health conditions or issues with mobility and balance going on, then we need to take further considerations in terms of some of our exercise prescription. Okay, so the guideline talks about endurance or cardiovascular fitness, resistance training, balance, and flexibility. And we'll talk about these a little bit as we go through because I think that some of them are really interesting. So the endurance background is that we were trying to accumulate 150 minutes per week of moderate intensity, at least moderate intensity, cardiovascular fitness training in the given week. So on a scale of 1 to 10, if we're using a rate of perceived exertion, where 1 is lying down and doing nothing and 10 is going as hard as you possibly can, we are looking in that 5 to 6 out of 10 range. For that, we're thinking, we're breathing heavily, but we still can carry on at least some of a conversation because we're not huffing and puffing so poorly or so much that we can't speak. Because I have that sometimes when I work out. Okay, so the flexibility training, so that is twice a week on major muscle groups that may be impacting our ability to go through day-to-day tasks. As we get older, we do have stiffness that accumulates around a lot of the joints, particularly the joints in the spine, hips, and knees. But that does not mean that the only thing that we should be doing with exercise-based prescription is getting people to stretch. Sometimes that is the perception of some of my clients who come into the gym, that their stiffness is largely a result of muscle tightness rather than their stiffness is a result of instability, which is creating a feeling of stiffness across those joints. And I think that's a really important consideration to make when we're talking about the flexibility training, and the guidelines don't support having flexibility training every single day. If it's part of the warm-up cool down, that's totally fine, but sometimes when we're thinking about the biggest bang for our buck, the flexibility training may not be there. Okay, number 3 is resistance training. I'm going to say right now that this is where my bias is, especially because this is probably the area of fitness that requires the most amount of supervision from a rehabilitation professional, whether that be in fitness, physio, chiro, whichever part of the rehab spectrum you are working with. And so rehabilitation guidelines, fitness guidelines for strength training are at least twice a week, looking at major muscle groups, selecting 8 to 10 exercises in the 8 to 12 repetition range at a moderate to vigorous intensity. Moderate to vigorous, so 5 to 6 out of 10 to 7 out of 8 out of 10 for some of these guidelines. Okay, the 4th one is balance training. So the indications for balance training are related to people who have had frequent falls, or for people who have issues with balance and mobility around the community. Those are the 2 indications for incorporating more balance training into an older adult's exercise prescription. So those are just the 4 guidelines. I won't really speak more about the balance training. That's for another episode. Okay, so we have those 4 guidelines. When I read those, or when I have students who come to me and say, okay, well, I know the exercise prescription guidelines, but they seem relatively vague. So it can be anything in cardio, or anything in strength training, or anything in flexibility. And so how do we as clinicians, how do we particularly as new grads now apply some of these exercise prescription guidelines within our practice? Okay, so the first thing that I want to talk about is when we have a person who is in front of us, what are some of the first things that we do? And when I'm lecturing about exercise prescription for an older clientele, I always talk about trying to establish a person's traffic light. What do I mean by this? Okay, so if we think about a traffic light, we have 3 components. We have the red light. These are our contraindications. We need to make sure that we are asking the questions that would exclude a person from safely taking part in an exercise program. So I mean finding out if they have unstable hypertension that hasn't been treated by a doctor, if they're having unstable angina-like pain. And there's a list of these contraindications in the ACSM exercise prescription guideline. So that's number 1. We want to figure out, even if pain is what is inhibiting a person, and right now they are just not in a position to be taking part in certain aspects of the exercise program you had originally intended to work with, we need to find what those are. Okay, we've established, okay, they have no red lights. We're pretty good to go when it comes to some of the things that we had in mind for today. Okay, next we go into the yellow lights. What I mean by these are the exercises that are going to be really important for a person from our opinion and in conversations with the client in front of us, but we need to proceed with caution. So what we want to do is, for example, something like floor transfers. So if I want to get a person eventually to be able to get up off the floor because they have a fear of falling, for example, I would probably put that into a yellow light category. I'm going to start taking the steps from day 1 to establish the prerequisite amount of strength that I would feel confident getting a person on and off the floor, but it's something that I'm going to have to proceed with caution. 1, because it might be a lot of effort for a person. 2, there may be orthopedic injuries that are going to result in pain or discomfort trying to get into the range of motion that we need to get a person up and off the floor. Or 3, a person may not have the confidence, and because of that, it may actually affect our therapeutic alliance with that individual because we're pushing them to do things that they're not ready to do yet. And so if that's the case, then we want to make sure that we're proceeding with caution. We're in this yellow light. It's still important. We should still try and go forward with it. We're gunning through. But we want to make sure that we're doing it in a safe way that's going to maintain the trust and confidence of our clients in us as physiotherapy providers. And then number 3 is our green lights. Things that we know are going to be really beneficial for an individual, isn't going to cause pain or discomfort, and is going to give people a sense of accomplishment and that they got a good workout, or that's something that they feel really good about themselves for being able to accomplish. So that's kind of where I start. So if I know kind of where the person's goals are for coming in for exercise-based prescription, what we know that the research is supporting, and some of the things that we're trying to categorize, red lights, yellow lights, green lights, then I have a good solid foundation for starting in an exercise prescription capacity. Okay, often as physiotherapy providers, we see people in a snapshot. So if it's 6 or 8 treatments or something, but I also want to talk about long-term exercise prescription. So not just in that particular moment where we're working predominantly on therapeutic exercise, but also how we as physiotherapists who are movement experts and exercise selection experts can program for an individual across time. So whether that be 4 weeks, 6 weeks, 12 weeks, kind of getting that individual ready for long-term exercise prescription or forming a healthy habit. So what we've seen in athletic populations is that we tend to go through different periodization schemes in order to maximize the benefits of exercise in those individuals. And there's different types of periodization schemes. We have a linear periodization where people are increasing each week and then having a deload and then increasing and having a deload. We have block periodizations where we do the same exercises with slightly different rep schemes and set schemes within a block, and then we deload and then we start a different block with a different focus. An example of that would be like a strength focus where we're doing 3 to 5 repetitions in the first block, deloading, then turning to a hypertrophy cycle where we're increasing the rep range to try and get a little bit more stimulus to increase muscle size, and we're in that 12 to 15 rep range, and then we kind of go to the next block. The third one that's become really popular is DUP, so daily undulating periodization, which means that every single day we're switching. We're going back and forth between today we're going to do a 1 rep max, next day we're going to do a 5 rep max, next day we're going to do a 3 rep max. And so they've started to try and see if we apply these principles for community dwelling older adults, are we going to have the same effects that we're seeing in athletes, where a certain periodization scheme is going to be more beneficial than a random schema of strength training programming going forward. Okay, so in November of 2017, so just this month, in the Journal of Strength Conditioning Research, there was an article published by Conlin and colleagues which compared these different periodization schemas on not only different parameters of physical function and things that would be a successful resistance training program, like increases in strength and mobility, but also on enjoyment. So that's the other thing. We need to make sure that the person who's coming in isn't hating whatever exercise we have selected for them. And what they showed was it didn't really matter. So for a community dwelling older adult, we don't need to get complicated in terms of our periodization schemas, as long as there is progressive overload. And that is the most important thing, and something that we as healthcare professionals, myself included, can sometimes slack on, I guess, is that we're not progressing an individual in the way that we need to be progressing them. And it's a trial and error. Sometimes have I overdosed individuals? Yeah, and I've flared them up and I felt awful. And then on the other end, have I underdosed individuals? And the answer is yes, because I look back and they could have been doing so much more than what I had given them from an exercise-based perspective. And so we have to try and find where that person's sweet spot is in terms of progressive overload. And that tends to happen with a lot of conversations with individuals about how they're feeling, how they're doing, how they're feeling after. And sometimes that means that I need to explain to, especially some of my older clients or people who haven't been taking part in exercise for a really long time, what it means to have joint soreness versus muscle soreness. And it's not an easy thing to explain, and trying to explain that having some of that muscle soreness is normal, it can be quite the interesting conversation sometimes with my 80-plus-year-olds. Okay, so we have a person's traffic light. We kind of know that we're seeing them for a long period of time. Now, how do we get started? And if I have a training session, I'm thinking that I'm seeing a person for 30 to 45 minutes, I try to set my priorities. So if I was looking for an individual, if I was looking at an individual, I did an assessment, I saw that lower body functional mobility was a definite weakness of theirs, then that would be priority numero uno. So when they're coming in, I'll have them warm up appropriately, do any mobility work that they need to safely get into the positions that I'm trying to get that individual into. And then from there, priority number one is the one that's going to take the most amount of effort, is going to be potentially the highest risk, and is going to be the most strenuous on that individual. So for example, if I am going with that getting up off the floor, if I have an individual that, say, I'm trying to get them to do floor transfers, and for them that's going to be something that is going to be this mountain that they need to climb, and is going to be something that they find extremely difficult, I'm going to get them to warm up and start with that when their body is fresh, because I want them to have the most amount of strength and reserve and energy for that task. So that's at the beginning of my training session. And then from there, I'll continue with any accessory movements that I think are going to support that goal. So getting up off the floor, that might be, glute strengthening after, or quad strengthening, or hip stability, or core strengthening, whatever that person needs. and that's going to be my accessory movements. I often superset these movements with, with not the floor transfers, but the accessory movements, because I think that if we do that way, then people aren't getting bored, especially some of my older clients. Trying to get them to rest in between sets is really challenging because they want to go and get their exercises maybe done faster. But so I'll superset two different muscle groups that are different and aren't going to work to collectively fatigue one group, to try and get some of that accessory movement underway and do some of that core stability and stabilization that we want. And then after those accessory movements, that's largely when I will do an endurance-based prescription based on where a person is at. So for me, largely in the clinic, the strength is my focus, and then cardiovascular fitness is secondary. This obviously may change depending on your setting. If you're in a cardiac rehab setting, then the cardiovascular fitness is going to be priority numero uno to strengthen up the muscles around the heart. But it just depends on your setting. And again, that means setting your priority, where the priority for me is often strengthening in the lower extremity to improve functional mobility and ability to navigate around a person's environment. But again, cardiac rehab may be the difference. And then from there, I'll kind of set the plan. So if I have lower body strengthening as the priority, then I will say, we're going to take a rest the next day. Maybe we'll take 2 days rest, and then this is your homework for the next day. Whether that's working with me in the clinic or in a gym type of program where I'm looking at a home exercise program, depending on the equipment and the available space to the individual at home. And so we can kind of geek out about different tactics for exercise prescription, but that's kind of the basic framework that I use within the clinic that has the evidence-informed kind of rationale. So we have the evidence from the ACSM guidelines, and then we have to start thinking about ways to conceptualize this in the clinical setting so that we can help some of our colleagues, new grads, and clients figure out how to work on this exercise prescription skill. The last thing I wanted to finish off with is that if anybody is looking for a good resource on exercise prescription or high intensity resistance training with an older adult, I would definitely recommend the Barbell Prescription. So this book was released by Dr. Jonathan Sullivan. He's an emergency room physician. I think he's in Michigan. And he was a physician who kept seeing people falling and coming into his ER, and recognized that one of the biggest reasons for these falls taking place was a lack of lower extremity strength, and that was a priority for the aging population in the US. And so he started a gym called Gray Steel, and he essentially took a lot of the background research in exercise prescription, and then he talked about how to modify some of the more complex barbell movements like the deadlift, the squat, the bench press, the overhead press for a master's athlete. And he breaks this down in chapters for over 40, over 50, over 60, over 70, over 80, and the master's female athlete. And it is an amazing, amazing resource, and you can get it on Amazon. So to build on some of the exercise prescription guidelines and to make you feel a little bit more confident around exercise modification and meeting your clients where they're at in terms of your exercise-based prescription, this is definitely a resource that I would be encouraging you to look into. All right, so that is it for today. I hope you guys got some good tips and tricks for you to use in your clinic today. On exercise prescription for some of your older adults. Make sure you are progressing them as appropriate, because we all know that that is the way that we are going to see a change. If you guys have any other questions, feel free to reach out to Dustin or myself around the Modern Management of the Older Adult course. January is coming up super fast, and the course is going to be here soon. I hope that Ellen, who is watching this, can put the link for me, please. And then I hope you guys have an amazing day. Keep working on those exercise prescription skills. Bye.